My name is Dr. Arjun Sahgal. I'm a radiation oncologist and professor of radiation oncology from the University of Toronto and the Sunnybrook Health Sciences Center. So it was a great pleasure to be here in Chile at the first Best of Astro in Chile. I was asked to be a keynote speaker and gave 3 talks. My first talk was on spine stereotactic body radiotherapy. And there's no doubt that this is an emerging indication. We are waiting for the high-level randomized trials to be done, but its role has been established certainly in patients with oligometastatic disease, radioresistance, reirradiation, and now even postoperatively. It's very important that we do this technique properly, as it requires a large degree of sophistication in terms of delivery. So we discussed what the technique is, what the evidence is, and how we move forward. And again, we await 2 critical randomized trials, one being RTOG0631, and the second is the Canadian SC24 study, and we hope to get these data within the year or 2. The second lecture today was based on hypofractionated radiotherapy for brain metastases. There's no doubt to me that for patients with larger brain metastases, hypofractionation is going to be the standard of care. There's no reason why you should be giving 14 or 15 gray when you can hypofractionate. The data are clear that there is a benefit in terms of local control, less radiation necrosis, but randomized trials are needed. Certainly for postoperative cavities, I think we will see in the randomized trials that are being conducted the benefits to hypofractionation, as these targets tend to be irregular, and the target is essentially the rim of normal brain tissue surrounding the surgical bed. We talked about novel methods also to approaching patients with multiple brain metastases. We have a technique that we call SBRT that essentially divides the treatment over multiple days so that we can deliver focused radiosurgery, either as single fraction or hypofractionation, but get through treatment of patients with 20 or 30 brain metastases over a few days that limits toxicity. I think this technique will become the mode of the future. There is no doubt that whole brain radiation has seen its time, and the role of whole brain radiation for patients with 1 to 4 brain metastases is essentially contraindicated as a sole modality therapy. And we remain to see the data from the randomized trials for the patients with 5 to 20 brain metastases. And we have such a trial also at Sunnybrook looking at whole brain plus SRS versus SRS for patients with 5 to 20 metastases. Now in this trial, we did not have a whole brain arm, because we feel that it puts patients at disadvantage if we treat with whole brain alone, and we have to look at this question in a different way. The third talk was about glioma. The role of radiotherapy in glioma has been pretty much stagnant. We treat patients with glioblastoma with 6 weeks of radiation. We've shown that in the elderly, 3 weeks of radiation is really the standard of care with temozolomide. But the era of hypofractionation in 5 fractions or fewer with glioma is unclear. I think we will learn more as we get better data and randomized data looking at these novel fractionation schemes as compared to standard conventionally fractionated radiotherapy. But moreover, we really have to understand the role of margin reduction. With the use of advanced MRI, hopefully we can reduce the CTV and try and radiate less normal brain tissue for patients with glioma. And I think that's really the future. And there have been some initial data, particularly from Stanford, looking at margin reduction and dose escalation that has a lot of promise. But we need to advance this field further. And I think the role of MR and RT using MR LINAC-based therapy is going to have a major role in the treatment of glioma, not only in terms of margin reduction, but also in terms of tracking, monitoring, and potentially guiding treatment like dexamethasone for symptom control by imaging patients daily. But ultimately, we want to use technology like MR and RT to be able to biologically treat areas of radioresistance while dose de-escalating radiation-sensitive regions within the tumor, because we know that these tumors are heterogeneous. So I think there's a lot of excitement still in the field in terms of what we can do for glioma and radiation. And those are the nature of the 3 talks that I gave at the Best of Astro in Chile, and again, it was a pleasure to be here.